Great. Hi, good afternoon, everybody. Welcome to our Improvement Palooza 2022 Conversation Circle. Today, we're very excited to discuss with you the importance of health literacy and parent education in the NICU with an esteemed panel who we'll introduce shortly. Next slide. In terms of meeting logistics, I'm going to pass it on to my amazing partner, Janine Bonert, to share some of the housekeeping with you.
Great. So this is a meeting that we want to have people engage in conversation, hopefully, and discussion. So we have a couple presentations at the beginning, but you do have the ability to unmute and ask questions and talk. Feel free to use the chat. And a note just to mention that we will be sharing the slides and recording on the CPQCC website following today's session. For anyone having technical sort of difficulty with Zoom, feel free to send me a private message. And then we will be offering CE credit to RNs. So at the beginning here, for those that do want CE credit, please go ahead and chat in your name. Just send it to everyone. It records it in our chat that way. And at the end of the session, we'll have a link and a QR code where you can fill out an evaluation. So any questions about that, feel free to reach out to me. My CPQCC email is janine@cpqcc.org.
Thank you so much, Janine. So again, welcome. My name is Ashwini Lakshmanan. I'm a neonatologist and chair of the outreach committee this year. So thrilled to be here with you. Today we'll start with a Jamboard question, which Janine will walk us through in a minute. And then we have Dr. Lee Sanders with us today, who will be presenting on health literacy or health equity through a health literacy lens. And then Tanya Hatfield will be presenting on parent education through the lens of adult learning theory. And then the part that we're most excited about, which is our panel discussion. So really, we're hoping for engagement from all of you. Feel free to turn on your video and audio, as Janine mentioned, whatever you feel comfortable with, because we really like to engage and hear your experiences and really have this as a conversation circle. So we're really looking forward to that piece. And then we'll close. So with that, maybe we can get started. Janine?
Great. So we wanted to use a little bit of interactivity with this webinar. So we've got a Jamboard pulled up, and I will share the link in 1 second here. You do need to be logged into a Google account in order to access it. So the link is in the chat, and we just wanted to see if you could post something on what was the last thing that you learned or something that you were excited to learn about, since this session is on learning and health literacy and adult learning theory. So go ahead and post a note into the Jamboard on the web. And feel free to chat in a comment if you aren't able to access the Jamboard online. Great, thanks for sending in your comments here.
We'll give everyone just a minute to see if we get any more interesting things. I love that. Sourdough bread, it's important. And neuroprotective care, that's wonderful, especially with our NeoBrain Collaborative. So it's fantastic. Oh, and we have some in the chat as well. Neonatal touch and massage therapy, maybe.
Yeah, I'll go ahead and add that one to the Jamboard.
Fortnite. That's excellent. food security, how to create education materials at appropriate educational levels for all parents. Oh, parallel parking on a steep hill. Sounds like San Francisco. Great. Epigenetics and mental health. Fantastic. We have a variety of things. We'll leave the Jamboard up, so feel free to post, and we'll continue our discussion. Next slide. So thanks so much to our planning committee. You'll hear from Tanya and from Lee, as well as thank you so much always to Janine and Courtney, and then and Carmen Powell as well will be joining for our panel discussion. So thank you, everybody, and to our outreach committee, our education outreach committee. Next slide. So we'd like to dedicate this session. We're going to try to dedicate each one of our conversation circles to a patient and family. And this session we're dedicating to Micah. He's the son of Jennifer Canvasser, the president of the NEC Society and an active member of our group here at CPQCC. So this is beautiful Micah. Next. Oh, perfect. So it's my pleasure to introduce Lee Sanders. Dr. Sanders is a general pediatrician and associate professor of pediatrics at Stanford. He's a chief of the Division of General Pediatrics and has joint appointments in the Department of Health Policy, Epidemiology, and Population Health, and the Institute for International Studies. He's a national expert in the science of health literacy, which applies a literacy lens to advancing maternal and child health equity, and directs the Stanford Health Literacy Lab, which aims to address child disparities in health and education by redesigning primary care with youth and families. So really, really thrilled to have you, Lee, and thank you for all your time and championing this cause with us. So I'll turn it over to you.
Thank you so much, Ashwini. I really have great gratitude to you, to Janine, to Courtney, to Tanya who's joining us, everybody in the CPQCC leadership for inviting me here. And I come here humbly and with inquiry to learn. I'm loving the Jamboard. So learn from all of you and learn from your best practices. So as Ashwini mentioned, I am a general pediatrician. I also direct our complex primary care clinic, which takes care of some of the most vulnerable children to come out of the NICU, kids with multiple chronic illnesses. And so I thought I'd just start with one family and then move on to one task. So if you can move on to the next slide. This is an example of one family. I've actually practiced pediatrics, I was saying earlier, on both coasts. So this is a de-identified version of one family, although these families have given me permission to share their photographs. So the girl I'm examining there is a 7-year-old girl who's a former preterm infant born at 27 weeks estimated gestational age, who now has severe intellectual disability, congenital heart disease, chronic lung disease, and G-tube feeding. She's followed by 12 subspecialists, 5 community agencies, and has been seen across 3 different hospitals. I'm sorry, was there somebody who had a question there? Okay. In any case, she has 2 sisters, one of whom is a 5-year-old ex-term young girl. You can see her there in the picture, and the other is a ex-32-week preemie. She's 4 months old. Seen there with her mother, who has limited literacy and limited English proficiency skills. So this is kind of a somewhat average patient we see in complex care. And the map that you see was not drawn by this family, but it's called a care map. It's drawn by a parent from a national collaborative. And I want to emphasize something about this map. It's meant to show what this family needs to navigate every week to meet the health needs of this one child in the center. And in the lower left-hand corner is the health delivery system in blue. So that includes hospitals and specialists and so forth. But the rest of their world is very much outside of the hospital and clinics. It's the schools, advocacy organization, community organizations, social supports, legal and financial needs that these families need to navigate. And what gets me up every morning and sometimes keeps me up at night is trying to figure out at a systems level what kind of system we need to meet the needs of this child in the center, but really everybody in this family. So that's what I mean by health equity, is really getting all these needs met based on the needs and not necessarily the resources of the family. So that's one family. The next slide describes one task. And this is a common task in primary care. In fact, it's a common task in some ways at the time of discharge from the NICU, and that is to dose liquid medication to an infant. We in the health literacy research community use this task to develop a way of assessing the health literacy of parents throughout the US. And so we administered this question to more than 400 parents across multiple socioeconomic backgrounds, cultures, and so forth. We said, your child has an ear infection. Here's the prescription that you get from the pharmacy. And in fact, here's a dosing syringe that not all pharmacies give you. Where would you dose the medication? Well, normally I would animate this and show you that to answer this question, a parent needs to find that information in the midst of what is called gobbledygook. That's actually a health literacy term, gobbledygook, on this label, and then find where to fill it out. And so what I want to ask you guys, because normally there would not be the red circle there, is if you were to administer this to all the families that go through your care, what proportion of them would get that question wrong? That is, that they would dose this medication outside a 10% error bar from where that arrow is drawn. So I just want you to think about that number. And we did this. We administered this test to as I mentioned, for nearly 400 families nationally representative. So then moving to the next slide, and because we're not animating it, there's the answer. It's about 50% of families get this wrong or right. I guess it's 50%, so it's right around 50%. And that's one example of what we mean by health literacy. And this is a challenge independent of educational background, as we'll get to in a bit. So if you go to the next slide, what I want to set the stage for our conversation are two constructs, two definitions. One comes from the U.S. Department of Education, and that's the definition of functional literacy, which is an individual's ability to use printed and written information to function in society, achieves one's goals, and develop one's knowledge and potential. In 2004, the Institute of Medicine, now called the National Academy of Medicine, came out with this definition for health literacy, which is really applying those same skills to health decisions, namely the capacity to obtain, process, and understand basic health information needed to make informed health decisions. So that's the operational definition that we use, that we study, that we measure. Next slide. And based on that definition, this is what we know about the health literacy skills of adults in the US. This was unfortunately most comprehensively examined more than 15 years ago in 2006, but there were two large examinations of the health literacy skills of the US population done in 2003 and 2006, where more than 15,000 US adults representative of the country were given a test, an applied literacy test that included health content. And it was determined that nearly 1 in 3 US adults has below basic or basic health literacy skills. And I put up here some examples of that. These are individuals who struggle with understanding an appointment slip, what to do with it, dosing over-the-counter medication, similar to what I just showed you, entering basic information on a form, interpreting a growth chart, or taking a fairly low literacy form and understanding when their child's next vaccine is due. So that's 1 in 3 of our families. I put a little asterisk there because and it's good because some of you are concerned about that, particularly in California, we have a large number of our families who have limited English proficiency. Nationally, that's about 8 to 10% of adults who have limited English proficiency in addition to limited literacy. And in California, it's a little bit higher. It's closer to 12 to 14%. Next slide. And most people will not tell you this. And it's also not particularly practical. We can talk about this in the discussion, to screen for health literacy. And some people feel some shame associated with that. 2/3 of adults with low literacy have never asked for help, and most have never told people very close to them, including their spouse or their children. And there are lots of reasons for this. If you're interested, we can talk about it in the discussion, but it's part of the reason that we don't recommend screening for it in a medical setting. It's actually more sensitive than questions about sexual practices. And so therefore we urge what we call universal precautions, some of which Tanya will be talking about in a bit. Next slide. Nonetheless, despite knowing that there are limited health literacy skills for at least 1/3 of US adults, we continue to put out information from hospitals, from health agencies and so forth that are written at a level that are too complex for most people to understand. So the median grade level, this is a vast oversimplification of the US adults, is somewhere in the 7th to 8th grade level. But most medical information, including insurance enrollment forms, health websites, and still most patient handouts are written above that level. There are a few exceptions to that we can talk about, but the vast majority of information is too complex for most of us to understand and use. And my colleague, Deborah Roeder at Johns Hopkins, at one of our health literacy meetings in 2008, called this public health malpractice. So I like to put that out there so it catches your attention. In other words, if we were to do this with give a medication or a recommendation that we thought most people couldn't follow, that's a claim you might be able to make. Next slide. So that's really, this is the model. There's a conflict between the skills and abilities of most of us and the demands and complexity of the information we put out there. And that's where we talk about health literacy. I should mention that these skills and ability, this 1/3 of US adults who have limited literacy skills, gets worse with age. So I'm aging as we age. It gets worse with less educational activity attainment, but it also gets worse in stressful conditions. And most of you work in NICUs. So when we're in stressful conditions, our cognitive capabilities, our health literacy is actually impaired a little bit further. Next slide. And we know that independent of socioeconomic status, that is independent of poverty, independent of ethnicity, that low health literacy is associated with poor health outcomes across the board. And for those of us who do research in maternal and child health, a number of child and maternal health outcomes that matter for us, particularly those that are sensitive to parental discretion, child agency, choice, right? Discretion. And so you can see a lot of those conditions here, mental health conditions, but also chronic illness management and so forth. Next slide. Here's a health literacy action framework that I've adapted from cognitive behavioral theory. Tanya is going to go into this a little bit in greater detail, the application of adult learning theory. But when we think about health literacy skills, where the rubber hits the road is in addressing any measure of health behaviors that are necessary for us to meet our health needs and result in health outcomes. And so that's health literacy skills are a combination of self-efficacy, our confidence in our ability to apply that knowledge to skills, modeling, whether or not we've seen it done, and outcome expectancy, whether or not we understand and believe that whether or not we carry out these behaviors, it will really matter for ourselves or our children or family members. So this is the model that I use still to conduct my research and really to do interventions in clinical settings. Next slide. There are health literacy strategies that you guys can implement, and we're going to get into those practical aspects in a second with Tanya. The way I like to think about it, there's a lot of individual things we can do, training ourselves and our team members, and putting in place more appropriate materials, and structural changes that we can implement by making things a little more standard through daily rounds, discharge policies, after visit summaries, and so forth. You might not be able to say this in detail, but this is the most common Bible for those of us in health literacy, written by Doak and Root in 1991, teaching patients with low literacy skills. I really recommend you get a copy of it. I don't think it's too costly, but includes within it this guide in the middle. It's called the suitable assessment of materials that you can apply to any materials you're giving, any patient education materials, parent education materials, to just get a sense of how literacy appropriate they are. And it's among a lot of other tools in this excellent guidebook. Next slide. Here are just some examples of things that have come out of my lab that we've tested. So color-coded lab forms, color-coded BMI charts, more easier to use guides for medication delivery, particularly liquid medication, and simpler action plans for the management of chronic illnesses such as asthma, diabetes, chronic lung disease, etc. So you can see some commonalities here with the traffic light themes, but really the goal is to use some principles of literacy sensitive care, fewer words on the page, more white space, and less jargon, some things that Tanya is going to reinforce in a bit. Next slide. Here's one example of something we put to the test, just published in Pediatrics last year. This is these are pieces of a low literacy intervention that we implemented at 6 sites nationally for obesity prevention, beginning in early childhood and infancy, actually, that was co-produced with parents of multiple cultural backgrounds and literacy levels. You can see the traffic light motif of the colors and some of the things I talked about. And it's really based around good goal setting and supporting families in really low literacy agency around caring for their own children. And we put it to the test, so it's efficacious, at least through 18 months. You can read more about it online. Next slide. And what I'm doing in collaboration with the Stanford Design School is really implementing human-centered design, bringing families and care providers into the design school, essentially into a startup, to co-produce health literacy solutions to advance health equity, really in 3 major domains. One of them is around Medicaid policy. That's in our policy lab. Health literacy is in the center of things. So you can see 2 examples of things that have come out of this lab: the green light, obesity prevention motifs, and also better liquid medication labels. And on the right-hand side, working with computer scientists to develop better care management tools for the medical home that really work at transitions of care from hospital to home, from home to school, and so forth. So that's sort of the vision. That's sort of the structure that I wanted to share with you. I'm really eager to hear everything that those of you who are joining us today are doing already, so we can really help learn from one another. I hesitate to say that I'm an expert in health literacy. Actually, nurses taught me everything I do, and there are a lot of nurses here. So I'm a learner. I'm a lead learner in this, and I want to learn from you today. So thank you. I think that's mainly what I had to share with you. And handing off the baton, I guess, back to Ashwini and then Tanya.
Thank you so much, Lee. Yes, I agree. A daily learner, all of us. So I'm very excited to introduce another one of our amazing colleagues, Tanya Hatfield, who's been working in the neonatal intensive care unit since 2008 and has been a neonatal outreach educator at UCSF Benioff Children's Hospital since 2015. She teaches high fidelity simulations, provides classes and resources to UCSF contract hospitals throughout California. She recently received her master's of science in nursing education, specifically on utilizing adult learning theory to make nurses more effective teachers. So Tanya, thank you so much again for participating, and so excited to hear from you.
Thanks, Ashwini, and thank you for that wonderful background on health literacy. That's a perfect stage for what I'm going to talk about. So the reason that I became passionate about health literacy and adult learning theory happened early on in my nursing career when my niece was born, and she was an undiagnosed diaphragmatic hernia. And she got rushed off to the NICU. And I remember standing in front of the monitor and staring at these numbers, and I had no idea what it meant. I actually called one of my friends back in the unit that I worked in to read off the vital signs so she could tell me if they were normal. It was like, with all the stress that happened and my loved one being ill, like all of that knowledge I had as a NICU nurse was gone. And so that completely, changed the trajectory of how I interact with families and our babies going forward. Years later, around 2014, when I was in school to get my degree in nursing education, I loved how much I learned from getting to know how adults learn and all the learning theories that that includes. And I realized that, so much of what we do at the bedside is educating. We provide so much communication and information, but nobody really taught us how to be effective educators. And so we end up doing what we experienced, which for university, high school, was mainly people talking at us. And so that's when my passion really became, utilizing these principles of adult learning to have, to be better educators at the bedside. And my niece actually turns 13 tomorrow, and she's doing great. So next slide. So we have a poll. I want to know, so everything that you shared in the beginning of the webinar about your last successful learning experience, what were some of the characteristics behind it? Did you get to select the topic? Did it build upon existing knowledge? Maybe you understood why the learning would benefit you. I think we have a different poll question. Shoot, I'm seeing the resources. Were you motivated to learn? Was there some reason that you needed to learn what was in front of you? Maybe you knew you could apply the knowledge right away or solve a problem that you had, and it might be other factors that aren't listed, or it could be none of the above. While you're all selecting this, I can share that parallel parking on a steep hill was my learning skill that I learned recently. I live in San Francisco and I avoid parallel parking at all costs, but I was lucky that the passenger seat had a very great teacher and I really needed to find a parking spot. And so I was very motivated to learn.
All right, we've got a good amount of responses in, so I'll go ahead and share these results.
Thanks, Janine. All right, so kind of across the board, it looks like everyone chose at least one of those main 5 topics. And so that motivation to learn, I mean, it's actually pretty split, but the motivation to learn, like, that's huge. Because whatever it was you were learning, you saw meaning in that. And so that became important and that triggered that internal motivation. So thank you for participating. So next slide. So the purpose of that poll was to get you thinking in terms of the learner. So shifting away from our role as educating or nurse or doctor or nurse practitioner, and really sharing this perspective of creating a positive learning environment. So these are some of the assumptions that were put forth by Malcolm Knowles about adult learners and the contrast of how adults learn versus children. And so the first one, independent and self-directed learners. Adults want to feel like they have a choice in what they learn. As a learner, it's a far different experience for me to register for a webinar that I'm interested in versus being told I'm due in 30 days for my annual safety compliance learning. We build on prior experiences. Adults have a lifetime of experiences and knowledge, and we know that knowledge retention is greatly increased when we apply new learnings to existing concepts, experiences, and emotions that we already have. We're drawn to learning with clear objectives and rationales. We want to know why. We want to know what's in it for me. If the content isn't relevant, people won't care. And that's just the truth. So our challenge is, how do we make these learnings, these things that we have to share, meaningful? And then these last two pair together nicely. The desire to learn skills they can apply immediately or solve a problem they have, and then that motivation to learn is internal. So just like a lot of you selected, we want to learn for our own reasons. We don't want to learn because someone else is telling us we have to learn. And it could be we want to boost our self-esteem, get a raise, develop new skills. I saw someone put in learn Italian on Duolingo, because you want to be proficient when you go to visit a country and speak their language. Next slide. So now, how do we apply these principles of adult learning to how we educate parents in the NICU? So the first thing is, we really want to focus on actively involving families in their learning needs. Remembering that adults are independent and self-directed. And so a lot of our education is prescribed, that we're going to have to go through this education, but it doesn't have to be in a specific order that we choose. So by utilizing tools like a discharge roadmap, families can review expectations throughout their entire NICU stay and have shared ownership of that process. This can also help encourage self-directed learning. So how are they going to get information and answer questions that they have from credible places when you are not there? And that might be happening at a 3 a.m. pump session when mom is on her phone. So how are we going to set our learners up for success? Additionally, when learners explore and discover the content themselves, that again helps to increase knowledge retention. Recognizing experience is a basis for new knowledge. So getting to know our learners, if we get to know them and know what experience they have, then we can cater our education to their life experience, and that will help them retain that knowledge. So knowing, do they have any experience with, taking care of nieces and nephews? Did they breastfeed their older children? If they've exclusively breastfed 3 kids and now they have a 25-weeker that's going to need breast milk fortification, that's going to be a different conversation, because now we're having to explain the relevance and the impact of why that fortification is important. Helping families understand why, making things relevant and impactful. So this doesn't mean complex pathophysiology, but this does mean that we need to use simple language to make our words meaningful. Because if our families aren't understanding what we're trying to put forth, if they don't see it as relevant, they're not going to retain that knowledge. Utilizing words like, this is important because it's going to keep your baby safe when you go home, or saying, I'm going to go over a few teaching topics, is now a good time, can really signal to families that this is a time to learn, and give them the opportunity to tell us, like, this isn't a good time. Assist families in solving problems and development of skills. So, So making sure that we're addressing the questions that our families ask us. Anytime a family member asks a question, that's a perfect learning opportunity. They are coming to us and engaging. And then solving problems. Like, the number one problem that parents have in the NICU is that their baby is in the NICU. So, how can we help them? If we can't solve that problem right now, how can we help them along the way and become parents of a baby, in the NICU, help them in that role. Maintaining positive learning environment and recognizing growth. I always kind of laugh that part of my job as an educator is being a cheerleader. It's really getting people excited about learning. And the more empathy and care we can show in our communication, the more our families are going to want to engage with us. And just like Lee said, building that self-efficacy, like that's so important, because when parents feel competent, they're going to engage more and they're going to take on more of their baby's care. So it really is our job to help parents develop their role as parents of a child in the NICU, but just a nurturing parent in general. So we want to create a safe, active, and collaborative learning environment. All right, next slide. So how do you learn best? So when we think about, whatever your skill was that you newly learned, and just in general learning, how is it that you learn best? We realize that it might be a combination of things, but for the sake of this poll, we asked you to choose one.
All right, I'll go ahead and end that poll and show the results here.
Great, so practice. Yes, a lot of practice, right? The see one, do one, teach one. So that's really common. And actually the listening and reading, actually all the other ones are on the lower end. We can go ahead and go to the next slide. So the thing that's really challenging is in the NICU, what do we do the most when we're teaching families? We talk and we give them reading materials. And, it's not always possible that we can make each communication and education moment a practicing or a teaching hands-on moment. But when we look at this pyramid of how much knowledge is retained by each learning style, we see that discussion here is 50%. And we can do that with every interaction. We can make each interaction a discussion, and that can increase retention greatly. I love this quote: "Tell me and I forget, teach me I may remember, involve me and I learn." Again, thinking about how do we involve our learners. Next slide. So, educating from our ivory towers, we don't want to do this. How we teach and communicate matters just as much as what we teach and communicate. We really want to change the goal from providing information into helping parents process, organize, and recall information and truly gain that knowledge. Next slide. This is a brief little example from Reddit, one of my subreddits, Explain Like I'm 5, where people pose questions and then everyone posts answers to answer the question as if they were explaining to a 5-year-old. So this question: why do needle ends not fill with a tube of skin like pushing a straw through cheese does? And the first answer, next slide, which I'm sure is very accurate, but it's a lot of words. And I'm guessing that even if we had plenty of time to review this and study it, once this slide went away, we would not be able to describe at our dinner table why a needle doesn't poke a tube of cheese out of our skin. So now the next slide. It's more like pushing a straw into a juice box. The pointy end of the straw punctures the opening and the film is pushed out of the way. And so what has happened is the way that this person is explaining it has made it meaningful for us. It's built upon our previous experience of we've probably all tried to open a juice box with that little pointy straw and that little film. And it's made things meaningful and understandable. So this isn't degrading or patronizing, it's understandable. And we can still say, it's a phenomenon called coring, and this is how we explain it. So both of those pieces are important. Next slide. So how are we going to continually effectively teach? So these are some other tips. So utilizing simple and clear communication, utilizing plain language, avoiding medical jargon. I mean, jargon is going to the automotive shop, and hearing all the things that need to be done in your car. And I just kind of stare back at the person and I'm just like, okay, like how much money is this going to be? And when is my car going to be ready? Because all the things you say are that gobbledygook. Well, that's kind of like our parents, like looking at their baby being like, when can I take my baby home? But simple, clear communication is valued so much by families. They want early, adequate, and comprehensive education. They want to be involved. We should be giving them resources that are available at all times a day, making sure there's ample pictures and illustrations. Making sure that our materials are culturally and literacy sensitive. Just like Lee said, we really need to make sure that they are accessible to all literacy levels, especially knowing that under periods of intense stress, that everyone's literacy gets affected. Making sure that our materials represent diverse backgrounds as well, that we should be seeing different races, our LGBT families, on not just our education materials, but imagery throughout our units. And then evaluating effectiveness, so important. Making sure that we're limiting our teaching topics and time during every opportunity. And then confirm that there's understanding before we move on to teach more. And we do that utilizing teach back methodology. So this is really a reflection of our effectiveness. Research shows that clinicians underestimate patients' need for information, and we overestimate our ability to convey information. So it really just starts with acknowledging the complexity of what you've shared with a family, and then showing empathy and concern and taking responsibility, saying, I want to know if I've done a good job of explaining this. You know, can you share what you've heard? Or, you know, in the world of COVID, when a lot of times there's only one parent at the bedside, saying, you know, if you were sharing the things that we discussed with your partner, what would you say? And that can also be helpful for family members to say out loud what they've understood. Next slide. So these are some of my favorite resources for parent education. All but one of them are free, are available in multiple languages online, have beautiful images. There's written materials, there's apps, there's audio podcasts, again, in different languages. So I really hope that if you've used some of these, maybe you'll take note of something new to take a look at. Please share if there's any other resources that you use that you've had a lot of success with. We would love to hear that as well. Thank you.
Thank you so much, Tanya. That was amazing and so thoughtful as always. So Janine, if you don't mind shifting us to sort of a gallery view so we can see each other if anyone wants to turn on their camera. I just wanted to introduce another member of our panel today who was kind enough to join us, Dr. Carmen Powell. Dr. Powell is the co-founder and co-director of the Leadership Education and Advancing Diversity LEAD program at Stanford, and serves as a clinical assistant professor in the Department of Pediatrics. She oversees a team of pediatric hospitalists and implements strategic efforts to improve clinical pediatric and newborn care, and is the site director for the Stanford affiliate, the Watsonville Community Hospital. So thank you so much for joining as well, Carmen. We appreciate it. I think maybe if you don't mind, I can start with you to just share your experience a little bit in terms of thinking about health equity and health literacy. And then in the meantime, if folks have questions, feel free to post in the chat or share via mic, because we'd love to spend the last part of our session engaging with you.
Thank you so much, Ashwini, and thank you all for this invitation today. I'm still work in progress and learning, so I do want to note that a lot of this work is ever evolving, and so that's kind of where my practice comes from. So just to give the background, I work as a pediatric hospitalist and one of our affiliate sites at Watsonville Community Hospital, where I direct our team of pediatric physicians here. And just to give you a sense of where we are based in Watsonville, we have a large Latino population here, many LEP and ESL families. So when it comes to health equity and also health literacy, is really kind of important to our practices here. And we also cover a level 2 nursery, newborn, and pediatric care. So I wear the hat previously. As you mentioned, I formerly was a co-director for our lead program at Stanford Medicine. I'm now on part of their steering board, but I do a lot of education when it comes to health equity and diversity and equity, inclusion, and justice work. And how do we really kind of train and prepare physicians, particularly residents and fellows, to really have these practices ingrained, and also teach back how we can look at this from our own different, departments, practices, and put that into actual practice for our patients. And so I was really proud to be a part of a group that actually looked at improving health literacy and for LEP and ASL families this past weekend in their presentation. But I say that because I think it's one thing to be able to teach it. It's another thing to do this in practice. And I think that's what I marked down in that last survey, is that, really to learn this well and do it well is to practice it yourself as a clinician. So I have the privilege to be able to practice this every day when I work with my patients here at Watsonville. And just kind of speaking to, I think for a lot of physicians, we're still learning about what are like the best modalities to use when it comes to health literacy. Fortunately, in pediatrics and particularly in neonatology, we're well versed with a lot of resources and approaches. But I think what's been really interesting the last couple of years is just with COVID in particular, just some of the both physical and other structural barriers that were existing at that time, and how hard it was to disseminate, information to our patients and our families with a rapidly evolving and changing kind of like pandemic and virus, and even as just healthcare providers, trying to keep up our own knowledge and familiarity with the different practices. So I think if anything, it was like an accelerated way of practicing health literacy, particularly during this time. And then as a result, we actually developed a perinatal process improvement committee to really look at our practices from health equity, also in a quality improvement lens, working with our OB and our pediatric department. So a lot of different ways to do this in practice. I will say there are some challenges, but I know there will be questions from the audience. But thank you for inviting me here today, and happy to answer more.
Thank you so much, Carmen. We can open it up to the group, maybe starting with, in your practice, what have you found to maybe be effective or not so effective in terms of communicating with families in your units? Anybody wants to share?
Is that to the panelists, Ashwini, or to the group, to the whole, to the?
I think to both. If anyone wants to participate from the group, if not, we can always come back to our panelists. Maybe we'll start with one of our panelists then. Maybe starting with Tanya. What have you found to be effective in your practice?
One of the things that I have found to be really effective was on the last slide of resources, the Cincinnati Heartpedia. It's an app that parents can put on their phone and really just explore if their child has a heart condition, and really explore and kind of play around and see what different hearts look like from the inside, from the outside, after surgery. And it's interesting, and parents have almost every time felt really engaged with it. And it was a great way to engage their other children too. So really things that they can explore more, that catch their interest. So lots of pictures. Videos are great too. And then going over those resources with them afterwards to see what questions they have after they've been given time to kind of ingest and reflect on what they've seen.
Thanks so much, Tanya. We have a great question from the audience. that maybe I'll start with Lee and anyone else who wants to share as well. Does anyone have an easy way for staff to report when they realize certain materials aren't at the appropriate literacy level? Lee, do you have thoughts on that?
Yeah, I have a lot of thoughts on that. So referencing my previous slides, that's probably going to be the case for the vast majority of the materials, based on what we've done up to now. And I have a way to report on them. I just have a suggestion, and maybe CPQCC can run with it about what to do about it. So if you use the SAM, the Suitable Assessment of Materials from the DOC, or you can just find it online, you can assess them. And so what we're trying to do in primary care is to create a national repository of information. And one thing that CPQCC can think about is the 3 tiers that we're trying to implement. So the first tier is send everything in, but focus on assets, materials you think are really good. That's the first tier, like that you're using. Sort of like the one that Tanya just mentioned around, the congenital heart disease modalities. That's the first tier. Second tier is, I have a lot of medical students and pre-meds that I train to use the SAM to evaluate materials. And that's the second tier. Assess whether or not they're appropriate. They might look to us to be appropriate. Maybe they're not, maybe they are. And then the third tier is work collaboratively to design and test materials at a systematic level. I think one of the concerns that I have when I come to panels like this is that I'm preaching to the choir. Like a lot of the people that join something like this want to be better educators, communicators. And I'm still learning. I know that I have a lot to learn, and I was focusing what Tanya was saying, and I want to improve. But the real way to change and improve the care for our patients is to change the system, and not just to focus on our individual practices. So materials are one way to change the system, right? Written parent materials. But if those parent materials are up on the wall, like they are in a lot of places, and not being used systematically, they're not very useful. So another way you can think about it is, how to make those materials more systematically, like low literacy materials, more systematically provided. And the last thing I'll say is that many children's hospitals and community hospitals have developed health literacy committees for just this purpose. And it's very important to involve people from the community in assessing them, not just as taking on a supposed expert, not really, or using a SAM tool. So anyway, I can talk more about that, but that's my answer. I'm sure Tanya and Carmen have better answers. So thanks.
Thank you, Lee. Do you have thoughts, Carmen?
Yeah, I was going to say, I don't know if I have a better answer, but I agree with everything you said. And also, I just see some questions in the chat. So some of the challenges is just, there's the health literacy, but then there's also making sure the materials are in the language that our patients speak. And so making sure we have bilingual resources. And something else that we also have to also think about is that we have a large Indigenous population. So families that speak Mixteco, and I am by no means fluent, and it's very hard to get those materials actually translated to those languages. And so 2 things that I know that our group has done, we've worked really well actually collaborating with our OB-GYN partners who work with Salud para la Gente, which is a FQHC in our community. And they have a wealth of resources that we kind of tapped into as a hospital group, because we realize our materials, essentially they come from like micromedics or different things that are a default of the system. So when you print it out, it will give you this very long list of like, what is bronchiolitis, and even as a practitioner, I'm like, I would never say this to a patient. So our group kind of informally would partner with Salud to get some materials specifically for our newborn nursery, NICU, and OB, particularly for COVID, to try to be aligned in some of the material that we were giving to families, because we would say maybe something in the hospital, but then they would go see their primary care physician and get something completely different, or just in a different literacy level. So I think there's opportunities to make sure we're kind of consistent in this practice. But then on the pediatric side, and particularly in the ED, this is where we contend a lot with this. We actually started using some of the resources talked about here, printing out our own. And so we give that as well when we're doing our education with families. So that's in addition to the discharge paperwork that they've received with staff. But I think there is, to that point of the system, how do you change these systems to already have this as a part of like how you provide information for families? How do you even look at your EMR systems, which we sadly are not on Epic. So that is a big barrier as well, as like, how do you kind of make this as automated as possible? Because I think that that will allow for providers and staff to actually start doing the best practices if it's already embedded into these systems.
Thank you so much, Carmen. Yes, and Lee. There's another question in the chat about using mannequins to teach parents, holding the baby with various durable medical equipment, such as a G-tube or feeding tube. Thinking about practice as a primary way of learning, and many parents may feel nervous about handling their infant, especially with additional medical equipment. Any thoughts around that from the panel?
I love that you brought this up, Caroline. This is something that can be so traumatic for our families. Like the first trauma being your child is in the NICU, and now we are asking you to practice something that you've never done before on your child. And so utilizing mannequins at the bedside is so important. And if you don't have a mannequin, if it's lost, you don't know where the G-tube doll is, grab a blanket roll and roll it up. Because it really just anything to give parents the opportunity to feel that they're not going to like further harm their child is really important. I think that's a great way even to help parents with doing skin to skin or doing a standing transfer of skin to skin, a really great way to provide that safe learning environment before they're actually asked to do it, to be proficient at it. So I absolutely love that. Thank you for bringing that up.
Yes, great point. Thank you, Tanya. Thank you, Caroline. There's some wonderful examples in the chat about the EMR using the appropriate language. So that's great. Another question that came up is around including parents in rounds and family-centered care, which was a topic of our Improvement Palooza. Any suggestions on that piece of it and thinking about education and rounds and inclusion of families?
Since we're going around, I'll try to take that one. I think it's a great idea. There folks, including Carmen, who know more about some of the adventures in family-centered rounds. But I'll just share an actual example from us implementing family-centered rounds in Jackson Memorial Hospital in Miami, and practicing teach back. So what Tanya was talking about was a form of teach back. It's kind of show back, but with a doll. And sometimes that can be awkward to start off with. But when we started doing it universally, it actually saved time. And I think there are two things that seem, among others, that people are a little resistant to around really implementing families on rounds. One is it will add time, and the other is that it's kind of an awkward thing to do. But I have found this almost always to be the case when, instead of going in there and saying what our plan is, we start with teach back. It changes the way in which we're delivering care for the better, and we're practicing the principles of adult learning that Tanya just referenced. And here's the image, and it sticks with me to this day. I had a medical student on rounds, and we went into a room of a mother with a young child, with a young infant, and I said, okay, I went through a very brief, less good version of what Tanya just did, and I said, practice some teach back. And the medical student literally woke up the mom, who wasn't the best, okay, but we could do this better, but said to her something like, what do you understand is going on with your child? And the mother woke up immediately, and she said, well, what I understand is that you're going to get an MRI of my child's brain today and decide whether or not there's communicating or non-communicating hydrocephalus between the third and fourth ventricle. And based on that, you guys are going to decide whether or not to consult the neurosurgeon. Okay. And from a medical model, what this did in a public hospital was flip everything. The medical student who thought was going in there as the expert all of a sudden looked over at the rest of us and said, what do I do now? It saved a lot of time. It showed the capacity. So this goes back to something I think Carolyn was putting in around assets in the families. Health literacy is not about deficits, it's about building assets. And said, we have a lot to learn from you. And so that's my example. I always echo forward, and I thank that mom. And I said, by the way, I'll be telling this story many years from now, and I still am. We have a lot to learn from one another. And I think that's the spirit of family-centered rounds. I think it's phenomenal where you can do it, and you can and make it more comfortable for families, because you really don't want to put them on the spot and so forth. But anyway, sorry, brief story. Stories matter.
Stories completely matter. I think that narrative is so important, and a topic that we're passionate about. The time has flown by, and so we have about a minute or two just to wrap up. So thank you so much to this amazing panel and to all of you for joining. We'll have a virtual space that Janine's going to talk about in a minute to continue our conversation. So Janine, if you want to put up our slides one more time. Maybe for time's sake, you can think about this and feel free to share on the Jam board. We'll include the link in the chat, but what will you take back to your unit from today's discussion? And then we can go to the slideshow, Janine. I think in terms of our takeaways, next slide. We talked about systems level changes, definitions of health literacy versus literacy, outcomes and complexity. We talked about adult learning theory and parent education, and talked about some simple concepts for teaching and communication. Next slide. So I'll pass it to Janine to talk a little bit about earning your CEs and next steps.
All right, great. So for anyone interested in earning contact hours for today's session, I'm going to post the link in the chat. You can also scan that QR code, and then feel free to reach out to me at janine@cpqcc.org if you have questions about that or need the eval link. So thank you so much. We also would like everyone's feedback. So even if you're not requesting contact hour credit, please do fill out this survey. That would be very helpful to get your feedback. And then we have a few things that we wanted to announce. Our next conversation circle as follow-up to the Improvement Palooza this year will happen on September 15th at 11 a.m. And that topic is going to be on family advisory, building a family advisory council in your local NICU. Hope you can join us. If you are not already on our mailing list, this has the website there as well as the QR code. You can sign up for the emails that you're interested in so that you get emails about these types of sessions and more. And we also would like to let everyone know that CPQCC provides QI awards to several groups, either individuals or QI teams. You can go to our website and take a look at those or scan this QR code here. And we will go ahead and close out.
Thank you so much, everyone.
Thanks for joining.